Welcome back. We are on chapter 25 and the second part, which is actually the urinary system. Let's begin. Tubular reabsorption quickly reclaims most of the tubular contents and returns them to the blood. And let me turn on my, there, my pointer. Okay, so the filtrate is now being returned to the blood. It is a selective transepithelial process where almost all organic nutrients are reabsorbed. Water and ion reabsorption is hormonally regulated and adjusted, which includes active and passive reabsorption. And there are ways by which tubular reabsorption happens. One is by transcellular route, and the other one is by paracellular route. So let's take a look at the transcellular route. The transcellular route, okay, this is a paracellular route. Let me just point out, okay, and the transcellular route is going through the cells. The transcellular route, solute, is actually where the solute enters the apical membrane of the tubule cells and then travels through the cytosol of the tubule cells and then exits on the basolateral membrane of the tubule cells. Right there, this is the basolateral membrane tubule, and then enters the blood through the endothelium of the peritubular capillaries. The paracellular route is actually different. It doesn't go all through here, but it goes all the way in between the cells. The pathway is between the tubule cells, which is limited by your tight junctions right here. But these tight junctions are really tight but leaky in certain areas such as your proximal convoluted tubule, where water, calcium, magnesium, and potassium, and some sodium actually is moved right in this route. And let's take a look at this tubular reabsorption that occurs in the transcellular and paracellular route. This is a different presentation of something that I have already mentioned to you in that particular little spot there. First of all, number one, okay, that's your number one right there. This is a transport across the apical membrane. That route there is a transport across the apical membrane. And that is actually what's called the transcellular route when it crosses right through the cells. It is diffusion. This is actually the type of diffusion where it moves right across, right through the cytosol of the cell. And the transport could either be right through the basolateral membrane, which often involves the the lateral intercellular space. Well, this one here often involves a lateral intercellular spaces because the membrane transportation or transporters will transport ions in these spaces. So these are the two ways. Okay, it could go here or it can make a detour right on the interspaces between two cells. Then from here, from the interstitial fluid, now the substances will now cross and move through the interstitial fluid and into the capillary. And this particular route, which is actually in between the cells, is what you call the paracellular route, which is the movement through the leaky tight junctions, particularly in the PCT, and the movement through the interstitial fluid and then into the capillary. Now, sodium transport across the basolateral membrane. This is actually pretty much what we're going to concentrate on doing here in this particular view. Sodium is one of the most abundant, if not the most abundant, cation in the filtrate. The sodium transport across the basolateral membrane of the tubule is via primary active transport. Sodium potassium ATPase pumps sodium into the interstitial space, and this is actually your interstitial space, guys, and then is swept by bulk flow into the peritubular capillaries. Now, there's actually several ways of doing it. There's transport across the apical membrane, just like what I mentioned in the previous diagrams. Sodium enters the tubule cell at apical surface via the secondary active transport or via facilitated diffusion through the channels. The active pumping of sodium at the basolateral membrane results in a strong electrochemical gradient within the tubule cell and eventually in the low intercellular sodium levels that would facilitate sodium diffusion and potassium leaks out of the cell and then into the interstitial fluid, leaving a net negative charge inside the cell, which also acts to pull the sodium inward. Remember that sodium is actually a charged ion. So whenever there is bulk flow of sodium from one particular part of the cell to another, it carries with it the charge, and it will create a strong pull of charges across the membrane. Sodium reabsorption by active transport provides energy because of its charge and a means for reabsorbing almost every other substance. Remember that, for instance, I always tell my students one particular thing that they can actually like remember in the movement of substances across the tubules is this: where salt or where salt will be going, water follows. Wherever salt is concentrated, water will follow there. And that alone is actually telling you how the transport of sodium is highly energetic because it's a means for reabsorbing almost every other substance. And one of the most important substances is actually water itself. Wherever sodium goes, water follows. Now, in the secondary active transport is actually in this particular process, electrochemical gradient that is created by pumps along the basolateral membrane, okay, along the basolateral membrane, gives uh, gives a push that is needed for transport of other solutes. Organic nutrients reabsorbed by secondary active transport are co-transported with sodium, and among them will be your glucose, your amino acids, ions, and some vitamins. Now, with the passive tubular reabsorption of water, here you have the movement of sodium and other solutes creating osmotic gradient for water. Water is reabsorbed by osmosis, aided by water-filled pores called aquaporins by two systems. Two systems. One is the obligatory water reabsorption, and this process involves a passive, unregulated absorption of water that automatically follows the absorption of solute. And primarily, the solute that we have here will be your sodium. It is not influenced by hormones. Aquaporins are always present in the proximal convoluted tubule. Then the second one is what we call facultative water reabsorption. This process involves the regulative and selective reabsorption of the final small percentage of water. It is adjusted based on the body's hydration status. Aquaporins are inserted in the collecting ducts only if the antidiuretic hormone is present. Now, passive tubular reabsorption of solute pretty much happens when solute concentration in the filtrate increases as water is reabsorbed. This event creates concentration gradient for solutes, which drive their entry into the tubule and peritubular capillaries. Fat-soluble substances such as some ions and urea will follow water into the peritubular capillaries down their concentration gradient. And for this reason, lipid-soluble drugs and environmental pollutants are reabsorbed even though it is not desirable. Take note of that, please. Right here, it is actually showing that the right here, all the movement of what I call this, the movement of solute here, the basal lateral membrane, pretty much is when when this particular, I think if I'm not mistaken, this is, I cannot see it, this is sodium. Yes, sodium, okay, is actively pumped and right across and is now going to enter into the membrane of the capillaries. Here you have the uh, downhill sodium entry, which is not the second one. Where is it? The downhill sodium entry at the apical membrane, showing you the downhill sodium entry. Then you have the reabsorption of organic nutrients. This is number third. Glucose, amino acids, and some ions, okay, right through as a co-transport right through the apical membrane. And fourth one is actually this part here, is actually the reabsorption of water. There you go. That's a reabsorption of water going right through. Reabsorption of water by osmosis with the help of aquaporins. Water reabsorption increases the concentration of the solutes that are left behind. And these solutes can then be reabsorbed as they move down their concentration gradients. And finally, which is actually the last one, it's actually the lipid-soluble substances that diffuses by transcellular routes. Oh, it's not yet done. You have also various other ions that follow suit, such as chloride, calcium, and potassium, and, and urea that will diffuse right through the paracellular route. And that's actually the paracellular route in between the two cells. So now we're going to discuss what transport maximum is. Transcellular transport systems are specific and very limited. Transport maximum, or otherwise what we call TM, exists for almost every reabsorbed substance. It reflects the number of carriers in the renal tubules that are available. When the carriers for a solute are saturated, then excess is excreted in the urine. For example, hyperglycemia leads to high blood glucose level that exceeds the TM and the glucose and if it exceeds, then the glucose would spill over into the urine. And this is actually the example right here. We know that normally all filtered glucose is reabsorbed in the proximal convoluted tubule. There should not be any glucose in the blood. So glucose does not appear, it's not supposed to be appearing in the urine. However, when the filtered load exceeds the capability of the tubules to reabsorb the glucose, urinary excretion of glucose does not occur, though you have a spillover of glucose in the urine, and you will find sugar in the urine when you have urinalysis. The proximal convoluted tubule. We're now going to have a summary of the tubular reabsorption. The proximal convoluted tubule is the site of most absorption. All nutrients such as, and this is your proximal convoluted tubule, okay? All nutrients such as glucose, amino acids are reabsorbed, and this is where 65% of sodium and water being reabsorbed. Many ions are reabsorbed here, almost all of uric acid and about half of urea, but later half of urea will be secreted back into the filtrate. Then you have the nephron loop. There you go. There is your nephron loop. Now, in the descending limb, this is descending limb. In the descending limb, water can leave, but solutes cannot. In the ascending limb, that's your ascending limb right there. In the ascending limb, water cannot leave, solutes can. The thin segment, this is the thin segment, okay, and that's the thick segment. The thin segment is passive to sodium ion movement. The thick segment has sodium, potassium, and chloride symporters and sodium hydrogen antiporters that transport sodium into the cell. Some sodium can pass into the cell by paracellular route in this area of the limb. Now the distal convoluted tubule, that's the distal convoluted duct, and collecting duct, that's your collecting duct. In these particular parts, reabsorption is hormonally regulated in these areas. And the antidiuretic hormone, or ADH, is released by the posterior pituitary gland and and it causes the principal cells of the collecting ducts, this is the collecting ducts, to insert aquaporins in the apical membrane, increasing water reabsorption. So increased ADH level can cause an increase in water reabsorption. Then you have the hormone aldosterone. These targets the collecting ducts or the principal, specifically the principal cells of the collecting duct. And of course, the principal cells also at the distal convoluted tubule. It promotes the synthesis of apical sodium and potassium channels and the basolateral sodium and potassium. The ATP is for sodium reabsorption and uh, pretty much is also affected. Okay, the ATP for sodium reabsorption is affected, and water follows. As a result, little sodium leaves the body. Without aldosterone, the daily loss of filtered sodium would be 2%, which is incompatible with life. And that pretty much you need to lose the right amount of sodium in order that you will be losing the right amount of water. So it functions to increase this hormone functions also to increase blood pressure and decrease potassium levels. Then you have the third hormone, which is called the ANP, or atrial natriuretic peptide. The atrial natriuretic peptide reduces blood sodium, resulting in decreased blood volume and blood pressure. This is released by the cardiac atrial cells if the blood volume or the blood pressure is elevated. Then, last but not the least, is the parathyroid hormone. It acts on the distal convoluted tubule to increase calcium reabsorption. Now, here's a table that you can use to read on the reabsorption capabilities of different segments of the renal tubules and the collecting ducts. It will pretty much explain to you the capabilities of the PCT. You have also your loop of Henle, etc., the distal convoluted tubule, and the collecting ducts, distal convoluted tubule and collecting ducts. Pretty much what I have mentioned to you, the mechanisms are actually written down here. Then we go now to tubular secretion. We have just pretty much, I have just finished with you the reabsorption process, or how the blood claims back what it has lost. But now through the process, after it has gone through the process of screening out what it took back in, the blood realizes that there is something that it needs to throw away. And the throwing back into the filtrate is short, okay, and pretty much very little, which means there's actually very, very little realization that all of this garbage, some of this garbage, very little of the garbage that we took in uh, should be taken in. We cannot take them in. We should return them back to the filtrate so that it becomes part of the urine. So tubular reabsorption, which is the reverse of reabsorption, occurs almost completely in the proximal convoluted tubule. Selected substances are moved from the peritubular capillaries, and pretty much this is actually the secretion. The green one is actually the secreted substances. The reabsorbed ones are actually in the blue. So um, they go back into the filtrate like potassium, hydrogen ion, and ammonium ion, and some drugs. Okay, creatine, organic acid, acids and bases, and substances that are synthesized in the tubules are also secreted. An example of this will be your bicarbonates. Okay, and tubular secretion is very important for disposing of substances such as drug or metabolites that are bound to plasma proteins. They are also used for eliminating undesirable substances that were passively reabsorbed. For example, urea and uric acid. It helps in ridding the body of excess potassium. Now, that's actually what you call the aldosterone effect. It is also used for controlling blood pH by altering the amount of hydrogen ion or bicarbonates in the urine. So there's very little of the green parts happening, this part here, but there's also a little bit on the distal convoluted tubule where you have the regulated secretion of potassium that is done by aldosterone. Urea is actually reabsorbed right there in the ascending limb of the thin loop of Henle, and then there's a regulated secretion again of potassium by that is limited or that is controlled by aldosterone right through the collecting ducts. But most of the things, pretty much without the hormone, is almost finished right through the proximal convoluted tubule. So one main function of the kidney is to make any adjustment needed to maintain body fluid osmotic concentration at around 300 milliosmol. And osmolality refers to the number of solute particles in 1 kilogram of water. 1 osmol is equivalent to 1 mole of a particle per kilogram of water. Body fluids have much smaller amounts, so they are actually expressed in milliosmols, and milliosmols is equivalent to 0.001 of an osmol. So the kidneys produce only a small amount of urine if the body is dehydrated, or dilute urine is actually produced if we are overhydrated. The kidneys accomplishes this by using what we call a countercurrent mechanism, where the fluid flows in opposite directions in two adjacent segments of the same tube with a hairpin turn. And there are two types of countercurrent mechanism, and these are your countercurrent mechanisms. And this is actually happening right through the loop of Henle. Okay, these two mechanisms happens as the substances that move in the two legs of the loop of Henle go in different directions into pretty much in two adjacent segments of the same tube that is actually um, connected by a hairpin turn. And these are what you call the countercurrent mechanism. And there's two of them. One is what you call countercurrent multiplier, and the other one is called the exchanger. Let's go for the first one. The countercurrent multiplier is the interaction of filtrate flow in the ascending, okay, where's the ascending? This is your ascending loop of Henle, or descending limbs of the nephron, of the loops of uh, Henle, right, most especially in the juxtamedullary nephron, where there is actually more of the production of concentrated urine right through and their receiving capillary is the vasa recta. So the countercurrent exchanger, on the other hand, is the blood flow. Remember, the multiplier is actually happening in the loop of Henle. The countercurrent exchanger is happening in the blood. This is actually the blood flow that is in the ascending limbs and ascending and descending limbs of the vasa recta. So this particular ascending and descending limb of the vasa recta is supposed to be in here, overlapping with the ascending and descending limb of the loop of Henle. Whatever is taken in here, uh, whatever is actually like released through here or thrown away here is going to be reabsorbed by the corresponding part by its corresponding partner in the vasa recta. And the same thing is happening here. Whatever is actually released here should be taken in by the reabsorbed here by the corresponding limb of the loop of Henle. So there's actually like an exchange between the peritubular capillary or the vasa recta and the loop of Henle. These two countercurrent mechanisms work together to establish and maintain medullary osmotic gradient from the renal cortex to the medulla. Okay, so from the renal cortex, okay, that's it. This is the cortical region, all the way down through the medulla, where the gradient runs from 300 milliosmol in the cortex to about 1,000, can you see that? 1,200 milliosmol at the bottom of the medulla. The countercurrent multiplier, the countercurrent multiplier will create the gradient. Okay, they are the ones that create the gradient. The countercurrent multiplier will create the gradient. The countercurrent exchanger will exchange and preserves the gradient. Then the collecting ducts can use this gradient to vary the urine concentration. Okay, so I want you to pretty much, I'm not going to discuss this in the first place. I'm just going to read right through what is there, but it's just going to give you what the current countercurrent and in terms of milliosmol, which section of the kidney will have the highest milliosmol. The 300 milliosmol is usually in the cortex, and you could see that. And then it gets to be very salty, and the osmolarity is actually increasing as it goes into right into the medulla and close to the tip of the papilla of the pyramids. So let's take a look at the juxtamedullary nephrons that create an osmotic gradient within the renal medulla that allows the kidney to produce urine of varying concentration. I will be giving you three different interpretations of this, okay, so that you will understand pretty much what the countercurrent multiplier and exchanger will be. So the countercurrent multiplier involves the nephron loop that depends on the filtrate flow that flows in the opposite directions, descending and ascending. So they're actually, one is going on descending, the other one is going on ascending. And because they are actually hairpin loop, where one of the loop is going descending, the other one goes ascending. Now, between these two, there's difference in permeabilities between the descending nephron loop and the ascending nephron loop. So this is your descending loop and the ascending loop. There's a different impermeabilities between the ascending loop and the descending loop. Active transport of solutes. There's actually active transport of solutes out of the ascending limb. The limbs of nephron loop are not in direct contact. They are not really touching each other, but are close enough to influence each other's exchanges with the surrounding interstitial fluid. The ascending limb of nephron, this is the ascending limb of nephron. That one is the ascending limb of the nephron, is impermeable to the water. So water cannot go in or out in the ascending limb of the nephron. And selectively, it is permeable to sodium. So it is impermeable to water, but very soluble to sodium and chloride, and are actively reabsorbed right here, right through the thick segment, okay? And some passively reabsorb in the thin segment. A lot of it is reabsorbed in the thick segment. The descending limb, this is the descending limb, right there is a descending limb of the nephron, is freely permeable to water. So here you go. Your ascending limb is impermeable to water. The descending limb is permeable to water. And impermeable to solutes, which means your sodium and chloride is capable of entering here because they're very permeable here, but not water. But here, water is very permeable, but the sodium and chlorine is impermeable. So water now passes out of the filtrate into the hyperosmotic medullary interstitial fluid that causes remaining filtrate osmolarity to increase to 1,200 milliosmol. And that's the reason why the bottom part now, okay, the osmolarity becomes very high, because uh, water is impermeable here, but sodium chloride is actually permeable. Here, sodium chloride is permeable, and therefore they keep on coming in, and they increase the salinity of the tube itself. So the countercurrent mechanism, the more sodium chloride the ascending limb actively transport out into the interstitial fluid, sodium chloride leaks out there, okay? The more water diffuses out of the descending limb. So this becomes very salty, and then water diffuses out because water is permeable in the descending limb. It diffuses out of the descending limb. And the more water that diffuses out of the descending limb, the saltier the filtrate would become. The ascending limb then uses the salty filter to further raise the osmolality of the medullary interstitial fluid. The constant difference of 200 milliosmol always exists between the two limbs of the nephron loop and between the ascending limb and the interstitial fluid. The difference is multiplied along the entire length of the loop from the 300 all the way to becoming 1,200 milliosmol right there at the loop itself. The difference is actually 900 milliosmol. Right through the entire length, that 900 milliosmol is achieved by the increasing osmolarity. So let's see if we can discuss this. Okay, first of all, we're going to be discussing what is only right there here at the bottom. In the first one, you have the countercurrent multiplication that is happening in the loop of Henle. The long hairpin loops of the juxtamedullary nephrons establish the vertical osmotic gradient by pumping solutes into the medullary interstitial fluid. The process relies on the opposing flow of filtrate and the specialized permeability of the loop's two limbs. The descending limb, that one, okay, in this section is highly permeable to water, just like what I mentioned, but relatively impermeable to solute. As the filtrate travels down into the hypertonic medulla, the water moves out via osmosis and thereby concentrating the filtrate. The filtrate entering the nephron loop is isosmotic to both the blood and the plasma and cortical interstitial fluid. Here, right around this area here, the water moves out of the filtrate in the descending limb down its osmotic gradient. This eventually, as the water moves out, This will eventually concentrate the filtrate more. And then here, it's pointing to the bottom. The filtrate reaches its highest concentration at the bend of the loop. Water is actually exited out of the loop, and inside it's already highly concentrated. So now goes back in reverse. Now the sodium and chloride are pumped out of the filtrate. Remember that you have a highly concentrated filtrate now. Now the sodium and chloride are now going to be pumped out. The filtrate is at its most dilute when it reaches this particular part, which is about 100 milliosmol. It is now hypoosmotic at this point to the interstitial fluid. So your counter current exchanger utilizes vasa recta, which is like the capillary that is for the juxtamedullary nephron, the type of nephron that would have a very long hairpin loop that goes into the medulla. And the vasa recta is highly permeable to water and solutes. The flow of blood in the vasa recta is also counter current at the hairpin turn, so blood can exchange sodium chloride and water with surrounding interstitial fluid as it moves through the adjacent parallel sections of the gradient. Blood inside the vasa recta remains isoosmotic with the surrounding interstitial fluid. Vasa recta is able to reabsorb water and solutes without undoing the osmotic gradient created by the countercurrent multiplier. The countercurrent exchanger preserves medullary gradient by preventing the rapid removal of salt from the interstitial space and by removing the reabsorbed water, which is pretty much like what it is supposed to do. Water in the ascending vasa recta comes from the descending vasa recta, or is reabsorbed from the nephron loop and the collecting duct. As a result, the volume of blood at the end of the vasa recta is greater than at the beginning. This is just a wonderful magic of how urine is actually concentrated and diluted. So now, let's take a look at the mechanism of forming dilute or concentrated urine further. The kidneys regulate the concentration of urine to maintain body's fluid balance or osmoregulation. This involves complex mechanism within the nephrons, primarily governed by the antidiuretic hormone and the countercurrent multiplication system. And pretty much here, the dilute urine is produced when the body has an excess of water and needs to excrete it. At low ADH level, when the hypothalamus detects a low concentration of solutes, which means low osmolality in the blood, and signals the pituitary gland to decrease the release of ADH. Through filtrate dilution in a nephron, the thick ascending limb of the loop of Henle actively transports the solutes, sodium, potassium, and chloride out of the tubule and into the interstitial fluid. But it is impermeable to water. So I have mentioned that already in my previous discussion. This makes the filtrate passing through it more dilute. The impermeability of water, okay, with the low antidiuretic hormone, the collecting ducts remain largely impermeable to water, preventing it from being reabsorbed. So the excretion of water, as the dilute filtrate passes through the collecting ducts, it is not concentrated and is excreted as a large volume of dilute urine, which pretty much restores the normal fluid balance in the blood. These are the three mechanisms for forming dilute urine. The mechanisms for forming concentrated urine. Concentrated urine is produced when the body needs to conserve water, such as during dehydration. Okay, this is by promoting high ADH level, or by creating medullary osmotic gradient, by water reabsorption, by recycling of the urea here, High antidiuretic hormone also increases the permeability of the collecting ducts to the urea, which is reabsorbed into the medulla and contributes to the hypertonic environment. Water moves out with the collecting ducts and is now permeable to water. And finally, the result of all of this becomes the concentrated urine. This, this water reabsorption leaves a small volume of highly concentrated urine to be excreted, conserving body water. Okay, so what is diuretics? Diuretics are often called water pills. They are medications that help the body get rid of excess fluid and salt through urination. They reduce the amount of fluid circulating in the bloodstream, which lowers blood pressure and relieves swelling. So, how does diuretics work? They work by targeting the kidneys, which are responsible for filtering waste and excess fluid from the blood to produce urine. They prevent the kidneys from reabsorbing sodium and other electrolytes. They don't reabsorb water and other electrolytes back into the blood. Water follows sodium. It's like I told you, wherever sodium goes, water follows sodium. So by increasing the amount of sodium and other electrolytes in the urine, diuretics also increase water excretion. This is exactly how you evaluate the kidneys and the functions of the glomerulus, which is actually urinalysis. We're going to do this in the lab. Next week, you're going to do this in the lab where urine is examined for signs of disease and can also be used for tests of illegal substances. Okay, so we're going to get this in. I'm not going to be discussing this, although I'm going to be discussing some important facts about the nature of how a urine normally must, so that when you get into the urinalysis, if you know what the normal constituents are in the urine, if you think you have anything that is abnormally high or abnormally low constituents, then something must be wrong. Now, in chronic renal disease, defined as a GFR that is less than 60 ml per minute for 3 months, the filtrate formation would decrease. The nitrogenous waste accumulate in the blood, and the pH of the blood becomes acidic. This is seen in diabetes mellitus as well as in hypertension. Renal failure, which is defined as the glomerular filtration rate less than 15 ml per minute, meaning this person is not anymore urinating, causes uremia. Here you have ionic and hormonal imbalances, metabolic abnormalities, and toxic molecule accumulation. Symptoms of this will be fatigue, anorexia, nausea, mental changes, cramps. Okay, and the treatment for this now is already like hemodialysis. So, urine, chemical composition of urine. Let's take a look at this. It is 95% water and 5% solutes. The nitrogenous waste in urine is urea from the amino acid breakdown. This is actually the largest among the solute component. You have uric acid from nucleic acid metabolism. You have creatinine, which is a metabolite of creatine phosphate. And other normal solutes found in the urine, these are normal, will be sodium, potassium, phosphates, sulfates, calcium, magnesium, and the bicarbonates. Abnormally high concentrations of any constituents or abnormal components such as blood proteins and white blood cells and bile pigments, pretty much that should not be in the urine, would indicate pathology. And here are your substances that is supposed to be in the urine. And if there's actually like presence of this in the urine, then you know that these conditions actually are present in the body. So let's take a look at the physical characteristics of urine. Usually it is clear. It may be cloudy, which pretty much uh, indicate urinary tract infection or something that you might have eaten or something that you might have pretty much like placed right there along the urethra, such as an ointment that sometimes people put. Uh, when you excrete your urine, those ointments get in there and it renders it cloudy. Okay, so make sure that when you are giving samples for urinalysis, make sure that your urethra has been completely washed and um, you have pretty much like urinated, and your second urine will be the ones that's going to be a very good sample because your urine should be clear and not cloudy. It is pale to deep yellow from urochrome. It's a pigment from hemoglobin breakdown. The yellow color deepens with increased concentration. There are abnormal concentrations such as pink, brown, or smoky, which can be caused by certain foods, bile pigments, blood, and drugs. The odor is slightly aromatic when fresh. It develops ammonia odor upon standing as bacteria will metabolize urea. It may be altered by some drugs or vegetables. Disease may alter the smell. Patients with diabetes may have acetone smell to the urine. The pH of the urine is about around 6 with a range of about 4.5 to 8. Depending on your diet, an acidic diet with a lot of protein and whole wheat can cause a pH drop. And an alkaline diet, a vegetarian diet, or prolonged vomiting or urinary tract infection can cause an increase in pH. A specific gravity is actually the ratio of mass of substance to mass of equal volume of water. And the specific gravity of water is 1. So the specific gravity of urine ranges from 1.001 to about 1.035 because the urine is made up of mostly water and very little of solutes. Now, so from the kidneys, how will the urine be transported and stored and eliminated out of the body? So the ureters, and these are your couple of ureters from the kidneys will now be bringing the urine or transporting the urine from the kidney into the bladder for storage. These are slender tubes that convey urine from the kidneys to the bladder, and they begin at around L2 as a continuation of the renal pelvis. They are retroperitoneal. They enter at the base of the bladder through the posterior wall. As the bladder pressure increases, the distal end of the ureters will close, preventing the backflow of urine. Urine cannot go back into your kidneys. It has to stay here, and it will actually make the bladder expand instead of going back. So the ureters from the wall of the ureter from inside out will be divided or is actually made up of 3 layers, just like the walls of your gastrointestinal tract. It will also be made up of an inner mucosa that's made up of transitional epithelium. It's not columnar like your like your intestines are, but instead this is transitional epithelium. So you have layers, several layers, multi layers, okay? Which transitional would look like what do you call this stratified cuboidal, but when it is filled with urine, it expands and it would look like it is stratified squamous when it is actually pulled apart. And then you have the second layer, which is the muscularis layer. These are smooth muscle sheets that contract in response to stretch. They propel urine into the bladder. Okay, this is actually your urine, your ureters. Gravity alone is not enough, but also but also must also be pushed by peristaltic wave action of the muscle. So the ureters the muscles of the ureters can actually push the urine down by peristalsis and is adjusted to the rate of urine formation. Sympathetic and parasympathetic innervation uh, would play a significant role in the peristalsis. The adventitia is the outer fibrous connective tissue cover of the ureters. This is actually the histology. You have the mucosa, that's actually the mucosa right there, okay? Then you have the muscularis layer, okay? And the adventitia, which is actually this blue area. Let's take a look at some of the clinical aspect, which is renal calculi, kidney stones in the renal pelvis. These are crystallized calcium, magnesium, or uric acid salts. Large stones can block the ureter, obstructing urine flow, causing excruciating pain, pretty much from the flank all the way down to the abdominal region. Now, nephrolithiasis is calculi in the kidneys. I think you have calculi in the kidneys right here. Okay, urolithiasis is calculi lodged in the ureter. So this is your ureter, and you got your thing there. Okay, that's urolithiasis. Okay, so many many can be removed. There, some of them are small, and you could be like passing them out without intervention. But the larger calculi, or those that are lodged in the ureter, can be removed endoscopically or surgically. Many kidney calculi can be treated with lithotripsy, a procedure that uses acoustic waves or radio energy to break the stones so that they're going to be passed out more easily. The risk factors here, obesity and elevated blood calcium level. And the prevention will be adequate hydration. So better drink a lot of water. Now we get into the bladder itself. The urinary bladder is a muscular sac that is really nothing but a temporary storage of urine. If you have the two ureters, the urine now is going to be delivered into the urinary bladder. And the urinary bladder temporarily holds it. And this bladder is retroperitoneal, but it is located on the pelvic floor, posterior to the pubic symphysis. In males, the prostate, which is inferior to the bladder, you have the prostate, which is inferior to the bladder neck, right there. Okay, but in the females, anterior to the vagina, it is actually the bladder is anterior to the vagina and the uterus. It has openings, three openings. You have the openings of the urine entering from the ureters. That's actually two. And the opening into the urethra. So you have three holes. And pretty much a trigon is a word that refers to the smooth triangular area outlined by these openings for the ureters and the urethra. Okay, so let's take a look at what's so important with the wall of the bladder. Well, the mucosa is again transitional epithelium, like the mucosa of the ureters are transitional epithelium. The mucosa of the bladder is also transitional epithelium. The muscular layer, pretty much um, the thick muscular layer, or what you call detrusor muscle, cumulatively called detrusor muscle, contains three layers of smooth muscle. Now, in the digestive tract, you have only your outer longitudinal and inner your outer longitudinal and inner circular muscle. Here they have three layers where there's an inner and outer longitudinal layers and a middle circular layer, and they're covered by a fibrous adventitia, except on the superior surface where it is covered by a peritoneum. So, the urinary bladder collapses when empty, and the rugae, those are actually the rugae, you could see it, appear pretty much, and they expand and rises superiorly during filling without significant rise in internal pressure. A moderately full bladder is about 12 centimeters long and about um, and can actually hold about 500 ml or a pint of urine. It can hold twice that amount if necessary, but can be it can burst if overdistended. The urethra is the muscular tube that drains the urinary bladder. It is lined also by epithelium that consists mostly of pseudo-stratified epithelium. Or I guess this one gets into the exam. What is the lining, epithelial lining of the urethra? It is mostly pseudo-stratified columnar epithelium, except the transitional epithelium near the bladder. So right here, near the bladder, right there, the urethra, most especially the urethra of the male, is actually transitional epithelium, like the transitional epithelium of the mucosa of the bladder. Okay, and then near the urethral orifice sphincters, it becomes stratified squamous epithelium right around this area here. Now, the urethral sphincter, the internal urethral sphincter is involuntary, and you have your internal urethral sphincter right around this area there. That's your internal urethral sphincter, those two triangular shaped areas right there. Okay? And then your external urethral sphincter, which is skeletal muscle with this, and it's actually a sphincter, so it is actually surrounding this urethra, and that's another external urethral sphincter. In the male, this picture here is really very small, but you have the internal urethral sphincter right there, and the external urethral sphincter is right below the prostate gland. Okay, just make sure that you know that because you will need to identify that in the lab. So your internal urethral sphincter would involuntarily be contracting, so you cannot really you cannot control your internal urethral sphincter. Okay, this is actually controlled by the um, the volume of the urine that is actually there. If it's actually if it reaches up to a certain point that you need to go, that thing will go. But the external urethral sphincter is voluntary. It's made up of skeletal muscle, and it also is there's a way that's actually a way. This is the way for us really to control when we want to void. The female urethra is only about 3 to 4 centimeters and is tightly bound to the anterior vaginal wall. The external urethral opening, which is anterior to the vaginal opening, is actually like posterior to the clitoris. The male urethra carries semen and urine and has 3 named regions. The prostatic urethra, it is named prostatic urethra right in this particular area where it's actually like surrounding the prostate, surrounded by the prostate gland. Then it becomes the membranous urethra right here in this particular small, very small area where it is in the intermediate part between the prostate and the penis. This this is actually the membranous urethra, very, very short segment. And it becomes spongy urethra from then on, all the way down to the tip of the glans penis. It now becomes the spongy urethra. So I am going to hold you responsible. I'm not going to go through the litany of reading all of this in the clinical homeostatic imbalances, the urinary tract infections with the urethra. Please read right through them. Okay. It is only for your, um, this is only for your information. I don't think I gave this in the exam. Now let's take a look at micturition reflex. What is micturition? Micturition is also known as urination or voiding. There are three simultaneous events that must occur so you can actually urinate. The first is contraction of the detrusor muscle by the autonomic nervous system. The detrusor muscle happens to be the muscle of your urinary bladder. So whenever it gets filled up, it contracts. Okay? Then you have the opening of the internal urethral sphincter. So it's actually the first sphincter right there at the base, okay, of the bladder that opens up. Then finally, if you can void, if you're able to void, then you decide because this is external, this is something that you can decide on. You could hold it or you can let it go. Okay, the last one will be the opening of the external urethral sphincter, which is done by the somatic nervous system by the since it is a skeletal muscle. However, in infants, where the somatic nervous system control is not yet so developed, there is actually what they call reflexive urination. It is mostly the action of the internal urethral sphincter. If the bladder is already full, the infant will urinate. The distension of the bladder will activate the stress receptors, causing the excitation of the parasympathetic neurons, and pretty much that would make them go. I am going to leave this. This is actually for you to be able to understand and review how micturition is controlled or urination is controlled. And I'm going to hold you responsible also for these homeostatic imbalances in micturition, okay, urinary retention. And I think we are already done. So this is the end of the urinary system.